Now, it is my pleasure to introduce Dr. Armando Tripodi. Tripodi is a full professor of clinical biochemistry at the Faculty of Medicine in Humanities University, Milano, Italy. His research is mainly focused on elucidation of coagulation mechanisms, lab diagnosis of coagulation disorders, standardization and quality control of coagulation tests, and lab control of anticoagulant treatment. He would talk to us on the coagulation changes that we see now with adults with COVID-19. It's also important to mention here that we've reached over 4,500 attendees in this session. I thought benign hematology would not compete with malignant hematology, but this is defeating my assumption. It is my pleasure to give the mic to Prof. Tripodi.
I wish to thank the organizers for this kind invitation to be here with you this evening. And during the next 20 minutes, I will talk about the coagulation changes in adults with COVID-19. Okay. These are my disclosure. I wish to start my presentation sharing with you this graph, which represents the time course and the severity of COVID-19. And as you know, the first occurrence in COVID-19 is the viral response, which is typically very high, very strong at the beginning, and then they start to decrease over time, as you can see here. On the other hand, the host-inflammatory response is exactly the opposite, as you can see here. It starts to be relatively mild at the beginning and then increase over time. On the top of this, we have the hemostasis alterations, which typically are very mild at the beginning and they start to increase over time. So whenever you interpret the results of hemostasis test in patients with COVID-19, you should take into account the stage of the disease where the patient is located at the moment. Otherwise, interpretation is quite difficult. Now, we know very well that the majority, if not all, the hemostasis abnormality which occur in patients with COVID-19 are due to high plasma levels of pro-inflammatory cytokines, which are observed in this patient, particularly in those admitted to the ICU. These pro-inflammatory cytokines are able to promote considerable derangement of hemostasis and also endothelial perturbation, which may lead to fibrin deposition and eventually to vascular occlusion, as it had been observed in these patients. It's difficult to find some information about the incidence of thrombotic event in COVID-19 patients because the information are very sparse. I would like just to mention this article, which is a meta-analysis, a recent meta-analysis of venous thromboembolism incidence in patients with COVID-19. And the authors here looked at the 30 studies with a huge number of patients, as you can see here. And the estimation was pulmonary embolism account for 12% up to 17% of cases. And DVT, the median value, the incidence was 14% up to 23%, as you can see here. So a considerable incidence of VTE in patients with COVID-19. At the very beginning of the pandemic, some Chinese colleagues published this study on abnormal coagulation parameters, and they reported that these abnormalities are associated with a poor prognosis in patients with COVID-19. And actually, they investigated a considerable number of patients, more than 180, as you can see here, and 21 were non-survivors. When they looked at the different results, the prothrombin time, pardon, can you hear me?
Yes, we can hear you. Can others please mute themselves? You can go ahead.
Okay, thank you. So the prothrombin time in this patient was a bit prolonged, as you can see here, but was slightly more prolonged in the non-survivors, as you can see here, a few seconds more. And the fibrinogen was elevated in all the patients, but was much higher in those patients who did not survive, as you can see here. And the same is valid for the dimer, which was elevated, but more elevated in those patients who were non-survivors. And the same conclusion is for the FDP, which has been measured in that study. The second study published in JAMA Internal Medicine by Chinese colleagues is this one, which has been published a few months later than the first one. And in this study, the authors investigated by bivariate Cox regression analysis those factors which seems to be associated with the progression of the disease to IRDS or death. And as you can see here from the hazard ratio, IL-6 was associated with the progression of the disease to IRDS and death, as you can see here, statistically significant hazard ratio. The prothrombin time was apparently associated with the progression to IRDS, but not to death, as you can see here. And the APTT was neither associated with the progression to IRDS nor to death, as you can see here. And finally, D-dimer was strongly associated with both progression of IRDS and death. And I think this result were the first to give some value to, particularly to D-dimer. There were some other papers publishing information on D-dimer. This one was on the utility of D-dimer in predicting venous thromboembolism, non-mechanical ventilated COVID-19 survivors, as you can see here. The authors here investigated different values of D-dimer to see whether they were predictor of venous thromboembolism. And as you can see here, the group of patients who had D-dimer more than 1 but less than 2 micrograms per ml had an odds ratio for VTE, which was 2.3 and was not statistically significant, as you can see here. But those patients with a D-dimer more than 2 but less than 5 had an odds ratio for VTE, which was close to 3, as you can see here, and was statistically significant. And finally, those patients with elevated levels of D-dimer amounting to more than 5 micrograms per ml had an odds ratio for VTE, which was close to 11 and was statistically significant. There was also a recent paper published on a Saudi multi-center study in Saudi Arabia. And here the authors found that the baseline D-dimer, as you can see here, is a risk factor for VTE with an odds ratio 1.3, which was statistically significant. And also the baseline D-dimer in this study was a risk factor for composite events, as you can see here. The odds ratio 1.3 and was again statistically significant. Now, all this information on the D-dimer should be taken with caution because they stem from a retrospective analysis. And by definition, retrospective analysis cannot distinguish between the causes and consequences for this parameter. So I think that D-dimer is very relevant apparently in the studies, but we should wait some results from prospective studies before D-dimer can be used for patient management. A few weeks later than the papers published by our Chinese colleagues, we started investigating our patient in Italy at the beginning of the outbreak. And we investigated particularly hypercoagulability in patients who were admitted to intensive care unit and reported some thromboelastography findings and other parameters of hemostasis I would like to share with you. For those of you who are not very familiar with viscoelastometry, I would like to show this tracing, with typical tracing of viscoelastometry, which is characterized by different parameters. The clotting time here, the clot formation time, which gives you information about the velocity of clot formation, and finally, the maximal clot formation, which gives you information about the maximal amplitude of the clot and its firmness. Now, you see here two typical viscoelastic tracing we found in our patient population. The solid line here represents the tracing from a COVID-19 patient, and the broken line here represents the tracing of an healthy subject. So you can see that the maximal amplitude of the clot formation is much higher in patients with COVID-19 than in the healthy subjects, and this denotes hypercoagulability in these patients. When we looked at the individual results, the distribution of individual results of the maximal amplitude in our patient population, we found, as you can see here, that the majority of patients had maximal amplitude levels which were higher than the mean of the normal range. And again, this denotes a state of hypercoagulability detected by thrombelastometry. Another group of research workers in Italy published more recently their paper in which they investigated the thrombelastometry profile by using another device which is commercially available. We used the ROTEM, we used TAG, they used the ROTEM, and as you can see here, the pattern of results were similar. Patients were hypercoagulable, as you can see here, regardless of whether the viscoelastometry was performed as INTEM, EXTEM, or FIBTEM, as you can see here. So, in summary, it seems that the viscoelastic parameters denote hypercoagulability in patients with COVID-19. More recently, we carried out another study in which we investigated hemostatic alterations in COVID-19. This is the front page of the paper published in Hematologica, and I take the opportunity to thank all the colleagues which are listed here who contributed to this collection of results. The aim of the study was relatively simple. We wanted to see the extent of hemostatic abnormalities, but also to see whether these abnormalities progress with COVID-19 severity. And to this end, we investigated nearly 70 hospitalized patients who were divided according to the intensity of treatment care, defined as low, intermediate, and high. And low intensity treatment care are those patients who required ventilation support only. In the intermediate treatment care, we included patients who required continuous positive air pressure with CPAP. And finally, in the high, we included patients who required intubation and mechanical ventilation. We investigated on these patients a vast array of hemostatic parameters, subdivided here as the IC parameters, which included the prothrombin time, platelets count, fibrinogen, and D-dimer, pro and anticoagulant parameters, including factor VIII, antithrombin, protein CNS, endothelial parameters, including von Willebrand factor and Adams-13, and finally, inflammatory parameters, including C-reactive protein and ferritin. Let's look at the results of the IC parameters, as you can see here. These are the results of the prothrombin type, the distribution of results in the three groups. As you can see here, the majority of patients had the prothrombin time ratio, which was quite normal. The range of the reference range is shown here by the red broken line, as you can see. The platelet count you see here, the vast majority, in the majority of patients, the platelet count was higher than the upper limit of the normal range. And also there was a close correlation between the three groups of patients as far as platelet count is concerned. Fibrinogen is shown here, and again you see that in the majority of patients, fibrinogen was elevated, was much higher than the upper limit of the reference range. And even here, there was a close correlation between the three groups of patients. And finally, the other parameter which is relevant for the IC is the dimer. as you can see here, all the patients had D-dimer levels which were higher than the upper limit of the reference range. And even here, there was a very good degree of correlation between the three groups. Now, we know that according to ISTH criteria to define overt DIC, we need to look at different parameters, which are PT prolongation, low platelet counts, low fibrinogen, and the dimer. Now, if you consider our results and also other results published by other authors, you see that among the hemostatic parameters, only elevated the dimer seems to be consistent with overt DIC in COVID-19 patients. And this contrasts with the earlier paper published by our Chinese colleagues in which they determined that the patient had DIC. What about the pro and anticoagulant parameters? These are the distribution of results of factor VIII activity. You see that the majority, I mean all the patients had factor VIII activity, which was much higher than the upper limit of the normal range. And also there was a very close correlation between the three groups. Antithrombin was quite normal in the majority of patients, as you can see here. And protein C was normal in some of the patients, but unexpectedly in the group, in the high group patient, the median level of protein C was quite high, as you can see here, it was close to 150%. Protein S was quite normal in all patients, as you can see here. And so in summary, from this observation, we can draw the conclusion that the pro and anticoagulant parameters are consistent with hypercoagulability in this cohort of patients. Then we investigated also endothelial parameters, and here we looked at the von Willebrand factor and the Adams-13, which is the protease which is able to degrade von Willebrand factor, as you know. These are the results, the distribution of results of von Willebrand factor antigen in the three groups. And again, you see that all the patients had von Willebrand factor antigen, which was much higher than the upper limit of the normal range. And again, there was a very close correlation between the three groups. These are the results of the ristocytin cofactor activity in the three groups of patients. Again, even ristocytin cofactor was elevated much more than the upper limit of the normal range. And again, there was a very good correlation between the three groups. When we looked at the ratio between ristocytin cofactor and antigen, we found that the majority, all the patients, as you can see here, had a ratio which was lower than the expected unity. And this means that most of the von Willebrand factor antigen molecules are probably dysfunctional in this cohort of patients. What about Adams-13? You see here the distribution of results in the three groups. In the first group, in the low group, Adams-13 was relatively normal, as you can see in most of the patients, but in the intermediate and the high group, Adams-13 started to decrease considerably, and you see that there was a good correlation between the three groups. What about the ratio between von Willebrand factor antigen and Adams-13? As you can see here, this ratio was higher than the expected unity in all the patients, and there was a very good correlation between the three groups in increasing levels of this ratio, which amounted to 3.4, 6.8, and 8.3 respectively in the three groups of patients. There were some other papers published over time in the literature in which the authors looked at whether Adams-13 could be useful just to predict mortality in patients with COVID-19. This is one of these papers, and you see from the Kaplan-Meier curve here that the authors concluded that those patients who had Adams-13 levels less than 70 units per deciliter had a poor survival, as you can see here. Another paper was soon later published in this respect, and you see again that here the authors concluded that those patients who had Adams 13 less than 30 units per deciliter had a poor survival, as you can see here. Now, as I mentioned for the dimer, also for Adams 13, we should think about using this value, these results for patient management, because again, these values have been obtained in retrospective observations, and therefore, again, here it's not possible to distinguish causes from consequences. So I think that in the future, we should, I would say, organize prospective studies to see whether both the dimer but also Adams 13 could be useful in patient management. So in summary, from these results, we can derive the conclusion that von Willebrand factor levels are consistent with a certain degree of endothelial perturbation in patients with COVID-19. What about inflammatory parameters? These are the distributional results of C-reactive protein. As you can see here, all the patients had C-reactive protein, which was higher than the upper limit of the normal range. And again, close correlation between the three groups, and the results are similar when we looked at the ferritin, as you can see here. Now, I can go to my conclusion. I think that these results are really reliable in telling us that COVID-19 presents with the considerable derangement of hemostasis, and this may vary according to the disease progression, and that's why it's important to take into consideration the stage of the disease where the patient is located whenever you interpret results of hemostasis in your patient population. And the second point is that abnormalities seems to be not consistent with over the IC and consumption coagulopathy as was previously reported. And finally, it seems that patients possess an evident state of hypercoagulability and endothelial perturbation, which might be responsible for the thrombotic events which have been found in these patients. There are some key issues which require urgent attention, and I think from now on we should start investigating these issues. For instance, we should start an accurate collection on the clinical presentation of any hemostasis abnormality in these patients. And I know there are, I'll say, many ongoing registry which are collecting this data, and I think the analysis of this data will give us the opportunity to derive some information for patient management. And also, the same is valid to define the usefulness of hemostasis parameters, for instance, as I mentioned, the dimer, but also Adams 13 in decision-making. We should organize prospective study for this. And finally, probably it is most important to organize randomized clinical trials in order to assess the effect of anticoagulation on the outcome of critically ill patients, and also, probably more important, the value of more intense thromboprophylaxis to improve morbidity and mortality in hospitalized patients. You know, at the moment, this area is really not very well explored because some clinical trials have been initiated, but actually at the moment there are no results. So I think that in the next future we'll know much more on this aspect. I stop here and thank you very much for your attention.